welcome Stephen Waldo to the podium for the next talk about optimizing appropriate medical therapy.
Thank you very much. And again, I want to thank the organizers of the conference, which has been absolutely wonderful. All right. Before I begin my disclosures, I receive unrelated research support to the Denver Research Institute from Abiomed, Cardiovascular Systems Incorporated, and Merck Pharmaceuticals. So as has been alluded to during the previous talks, peripheral artery disease is associated with significant cardiovascular morbidity and mortality. From that same seminal paper published over 2 decades ago, it was determined that patients with a mere diagnosis of symptomatic peripheral artery disease had a 4-fold relative risk of all-cause mortality. This was even higher for cardiovascular death or coronary heart disease death, where the relative risk rose to 11-fold. Further investigation has demonstrated that survival is inversely related to the severity of symptoms that are instigated by peripheral artery disease. Patients with critical limb ischemia fare particularly poorly, with a 10-year mortality that exceeds 80%. With this in mind, identifying the optimal medical therapy for these patients is critical, not only to preserve limbs, but also to decrease mortality. With this in mind, several guideline organizations have released recommendations on the medical therapies for patients with peripheral artery disease, some of which we've already discussed. Generally speaking, medications that have been shown to be efficacious in patients with coronary artery disease have also been given a Class 1 indication. Additionally, glycemic control, intensive glycemic control, has been given a Class 2A indication because of its importance in wound healing. With these recommendations in mind, I'll briefly go through some of the data that support them over the subsequent slides. The first, antiplatelet therapy. This has obviously been extensively discussed during the last 2 talks, but I think we can conclude that antiplatelet therapies reduce the risk of adverse events in most patients with peripheral artery disease. Again, the CAPRI study, which was already described, enrolled 19,000 patients with vascular disease and treated them with aspirin or clopidogrel monotherapy. Those that were treated with clopidogrel monotherapy had a 24% relative risk reduction in adverse events. Dual antiplatelet therapy may be even more beneficial for this patient population with critical limb ischemia. Another randomized trial taking patients with vascular disease randomized them to receive aspirin or dual antiplatelet therapy with aspirin and Plavix. Among those that received dual antiplatelet therapy with aspirin and Plavix, the relative risk of myocardial infarction was significantly less in the PAD cohort, which constituted about 3,000 of those patients. Oops. And this slide was shown in the previous talk as well. Patients that undergo revascularization may derive an even greater benefit from dual antiplatelet therapy. In this analysis, the authors identified 57,000 patients that underwent endo or surgical revascularization for symptomatic PAD, 20,000 of whom had critical limb ischemia. In this particular trial, they used inverse propensity weighting to match patients that were discharged with aspirin monotherapy or those that were discharged with dual antiplatelet therapy. And regardless of the revascularization modality that was used, dual antiplatelet therapy was associated with a significant reduction in mortality. Moving on now to anti-hypertensive therapy. So this too can reduce the risk of adverse events in patients with peripheral artery disease. The initial data that supports this recommendation comes from the HOPE investigators 17 years ago. Again, patients with vascular disease were randomized to receive ramipril or a placebo. Focusing on the subgroup of patients with peripheral artery disease, those that received the ramipril had a significant reduction in composite endpoints of major adverse cardiovascular events. Subsequent data has also suggested that ramipril may be important in improving walking times among patients with claudication, something that I won't expand upon today. The use of ACE inhibitors or ARBs has also been specifically evaluated in patients with critical limb ischemia. Focusing on approximately 400 patients from a single center cohort that were followed for 1 year, propensity matched patients that were treated with ramipril at the time of endovascular revascularization had a significantly lower mortality rate, as shown on the left of this slide. The adverse limb event rate, however, was similar between the 2 groups. Glycemic control. As you know, a large proportion of the patients that we treat with critical limb ischemia have concomitant diabetes. This ranges from 50 to 75%, depending upon the cohort that is investigated. Data has suggested that intensive glycemic control can reduce the risk of adverse events. Again, in another single-center cohort, among approximately 300 patients that were undergoing endovascular revascularization for CLI, those that had a fasting blood glucose above 140 during their pre-procedural labs had significantly higher primary patency rates compared to those that had higher blood glucose levels. Similarly, those with well-controlled blood glucose had significantly fewer adverse limb events, supporting the Class 2A recommendation. Statins. So statins have been demonstrated to be beneficial for just about everybody, and that includes patients with peripheral artery disease. In this observational cohort, patients that were treated with statins had significantly lower mortality rates than those that were not after being discharged for revascularization for PAD. Interestingly, the primary patency rate among those treated with statins was also significantly higher. This has been confirmed in a much larger registry, the REACH registry, which had 5,000 patients with peripheral artery disease. Once again, patients treated with statins had a significantly lower rate of cardiovascular death, myocardial infarction, and stroke. Amputation rates among the statin-treated patients were also significantly lower, with a hazard rate of approximately 0.6, depending upon the multivariate adjustment model that was used. Finally, tobacco cessation. Approximately 30% of patients that present for revascularization for CLI smoke in some cohorts, and in our population I would suggest that it's even higher. Among those 30%, approximately a third are able to adequately abstain from smoking for a full year after the revascularization procedure, and a third of those patients do so with the assistance of pharmacotherapy. For those that are able to successfully abstain from smoking for a full year after the revascularization, they have a significant improvement in their mortality, as shown on the left of this slide. The amputation rates among these abstainers is also significantly lower than those that continue to smoke. So with all this data in mind, how do we optimize medical therapy for patients with critical limb ischemia? I think the first thing to recognize is that medical therapy for peripheral artery disease and critical limb ischemia is woefully underutilized. In this observational cohort that was published earlier this year, only 38% of patients with peripheral artery disease were prescribed antiplatelet therapy. 35% were prescribed statins, 31% were prescribed ACE inhibitors or ARBs, and 36% were counseled on the importance of tobacco cessation. Perhaps most sobering, patients that are treated with these 4 guideline-recommended therapies have significantly improved mortality, as shown on the left of the slide, and significantly reduced adverse limb events. The first step in optimizing medical therapy for patients with critical limb ischemia is thus ensuring that our patients receive these 4 guideline-recommended therapies. In addition to those medical therapies, there are other things like regenerative therapies, including chemokines and stem cells that I think will be discussed during a subsequent talk. There are also ancillary therapies, such as hyperbaric oxygen and intermittent compression, that have shown some promise in single-center studies, but obviously need more investigation before they're ready for prime time. With that, I'm happy to take any questions at the conclusion of the panel. Thank you very much for your attention.